So we move on. Now I would like to ask again Professor Φιλιππάτος to introduce Dr. Antonis Pantazis, because Kostas Tsιούφης
No, I am here, Petros. I am here, Petros.
Oh, okay, good. Okay, Kostas, carry on.
Good afternoon to everyone. Many thanks also from my side to organizers, and especially many thanks to Professor Efthymiadis for this kind invitation. I enjoyed the two previous lectures, and now it's my great honor and pleasure to introduce Dr. Antonis Pantazis. Everyone knows the great job that Antonis has done in the field of cardiomyopathy. We like to thank Antonis from the Greek perspectives for this great contribution in the field, and we are looking forward to enjoy your talk, Antonis, Arrhythmogenic right ventricular cardiomyopathy from the past to the present. Antonis.
Thank you very much. My pleasure to be here, and I thank the organizers for inviting me. A very quick comment on what Franco said earlier. I think we are certainly looking for national data, and the earlier we move towards national data in phenotypes and genotypes, the sooner then we will get answers to these questions. But coming now to my own subject, it feels a bit strange to talk about the past and the present of arrhythmogenic cardiomyopathy in front of Professor Thiene and Professor McKenna, who are the past and the present and possibly future of arrhythmogenic cardiomyopathy. But I'll try my best to summarize a few points, which I believe you will be able also to see on your screen when I share mine. All right. Yes. I have no conflicts of interest for this talk. Starting from the past, as I have been asked to do, this is the perception of arrhythmogenic cardiomyopathy, of arrhythmogenic right ventricular cardiomyopathy, from the previous years, which is a right ventricle disease with thin areas which can probably or possibly become aneurysmal at some point, and they produce arrhythmia, and nothing very obvious macroscopically on the left side, which is obviously not the 100% right picture. But if we go much deeper into the muscle, what we will probably see is that in the gap junctions, there are proteins missing from the right place, and with immunohistochemistry, we can actually identify the proteins, the desmosomal proteins missing from the gap junctions, and this is in many cases the root cause of arrhythmogenic cardiomyopathy. Then the knowledge progressed to identify those genes which encode the information for the proteins which are responsible for arrhythmogenic cardiomyopathy. And as this knowledge was expanding, proteins who are not necessarily involved in the desmosomes were held responsible for the same disease. And this has expanded our understanding of this condition. At a histological level, the hallmark has been the fibrofatty replacement, although this is sometimes difficult to identify on a biopsy, but should be always present in a postmortem specimen because it can be patchy in the heart, but it should be there. However, information from individual patients has confused sometimes the picture a little bit when it showed great evidence of inflammation on a PET scan on this occasion, which makes one wonder whether this is a myocarditis that coincides with the arrhythmogenic cardiomyopathy, or is actually part of the mechanism. This is a case of a patient who has clear-cut desmoplastin mutation, has family history of the same, but his PET scan interestingly shows all this evidence of inflammation. He's, without this being accompanied by acute changes on the Holter monitor or ECG. So in other words, there isn't any evidence of the hot phase, as you call it or used to call it, in terms of the arrhythmia, but only in terms of the inflammation here. The symptoms have not been very many. In cardiology, we always look at probably 4 types of symptoms. And it has been a very, very interesting observation when a young child died with noxious disease, the recessive form of arrhythmogenic cardiomyopathy, and although the histology was normal, the ventricular extra beats were present in thousands on the Holter monitor, which means that the first changes were in the electrical abnormality rather than the histology, and also changes were present within the immunohistochemistry and electron microscopy, suggesting that there are ultrastructural changes first, which lead to electrical abnormalities, and the histological changes come later. Now, the scary thing about this condition has been that it can cause sudden death. The overall risk of sudden death is low, but because the condition may have a very subtle clinical course and sometimes remains undiagnosed, interestingly, a significant number of the probants were diagnosed after sudden death. Again, this does not mean that 45% of the people with arrhythmogenic cardiomyopathy would die suddenly, but it means that the sudden death was the cause of the diagnosis. Otherwise, the condition might have remained undiagnosed in the individual and the family. The ECG changes, especially at young ages, might have been confused on occasions with the normal changes of a young person's ECG, although looking at the ECGs more carefully, one could identify that this was not the case, and the ECG was abnormal. In this particular case, it was the T-wave inversion from V1 to almost V5 and V6, which was revealing, rather than the normal T-wave inversion from V1 to V3 in young normal individuals. And a very interesting other observation has been that the penetrance of this condition is quite low in the family. So having one individual affected, we wouldn't expect to see a strong disease presence in the relatives, but actually it was more expected to see a low penetrance of the disease in the relatives, which then poses both diagnostic but also risk stratification issues, because the family history is not a strong predictor here for anything. However, the known family history would have facilitated the diagnosis in people who have the incomplete phenotype. The diagnostic criteria have gone through a number of very serious, very systematic approaches, and first published by my good colleagues in the panel in 1994. They included criteria and information from a number of different domains, suggesting already that this was a challenging diagnosis which required a lot of information. And a review of the criteria in 2010 followed the same approach in terms of the domains, however, tried to quantify the criteria in a way that would be more accurate and more sensitive and specific. I will not spend time on this in the interest of time here. Obviously, typical would have been the T-wave inversion, as we discussed already, the high number of ventricular ectopy on the Holter monitor, and the structural changes and functional changes of the right ventricle. But what was extremely interesting in the early days, known to pathologists, we had this discussion with Professor Thiene a number of times, and he has always confirmed that he knew about it. It was only us cardiologists who didn't want to understand it, is that this disease was biventricular. And it was biventricular at a histological level, but sometimes was also biventricular at a functional and structural level. It's just the resolution of the cardiac imaging at the time was not good enough to pick up the changes in the left ventricle. So we have considered this disease as right ventricular for a number of years. Immunohistochemistry also confirmed that the changes observed in arrhythmogenic cardiomyopathy were observed on samples coming from both sides of the heart and not just from the right ventricle. And with the evolution of cardiac MRI, which was really a huge step in cardiac imaging and cardiac diagnostics, we have started identifying these changes in the left ventricle as well. Obviously, that's a very striking example, but even more subtle changes would have been diagnosed on cardiac MRI, plus the tissue characterization and the late enhancement in the left ventricular myocardium. As I said earlier, new genes beyond the desmosomal genes have been identified, and some of these genes had a quite distinct clinical course with a lot of arrhythmia with an aggressive phenotype, and therefore the genotype-phenotype associations have become very interesting in arrhythmogenic cardiomyopathy. Excuse me. A very important step also in the prevention and management of arrhythmogenic cardiomyopathy has been the observation that physical activity, strain on the heart, and eventually sports in the individual's real life would make the progression of the condition much faster, would cause more arrhythmia, and would cause the condition to manifest itself in a much more overt way. Experiments with mice and also observations in humans have confirmed that. So a dose effect, if I can put it this way, has been suggested for the presentation of arrhythmogenic cardiomyopathy, where the genetic change plays a role, but also the amount of sport that people do contributes enormously to the phenotype. And the two extremes are an ultra-endurance athlete who may have some expression of similar to arrhythmogenic cardiomyopathy, and someone who doesn't do any sport but has a strong genetic change. And everything else in the middle would have this dose effect. We know that the condition progresses over the time, over the years, and changes can become more overt, more obvious, and therefore follow-up of these patients is recommended. Now, the risk stratification has always been a challenging field in arrhythmogenic cardiomyopathy for a number of reasons. One of them is what I said earlier, that this variable expression and phenotype does not help in good and systematic approach and data collection. But another very important thing has been the lack of consensus in the definition of this condition between different centers, between the two centers and schools of thought on either side of the Atlantic. But what I think there is an agreement about is that some strong risk factors, when present, they need primary risk prevention, and that when there are no risk factors present, no action needs to be taken. For the cases in the middle, there's always been a lot of discussion, and we still individualize the approach and the risk prevention. Risk scores, like in all other cardiomyopathies these days, have been developed with which are in principle quite useful, and it's the right approach, which is in the direction of evidence-based medicine, AI, using AI, artificial intelligence, based on data, but the data are not there in cardiomyopathy. That's the real problem, and the data are not there more particularly in arrhythmogenic cardiomyopathy because of the heterogeneity, because of the lack of long cohorts and registries that would provide us with precise information so that we can make precise predictions. If the risk is high, medication can sometimes work, particularly beta blockers, but the implantation of a defibrillator is the ultimate risk protection. However, there is some risk for the VT ablation these days, not necessarily to modify the risk of the patient, but to give the patient ventricular arrhythmia-free years, which is a great benefit, even if this is to delay a defibrillator or to prevent shocks from a defibrillator. For both these purposes, the ventricular arrhythmia ablation could work. And it's also important to look at the lifestyle modification, given that sports and intense physical activity can provoke disease progression and arrhythmia. And there are patients who have actually responded very well to the advice to reduce the sport they were doing, and when they felt better and they started doing sports again, they had more ventricular arrhythmia. Now, I've mentioned a couple of times that the definition has been an issue here, and this is an ongoing problem. An extreme example of this is the definition of arrhythmogenic cardiomyopathy as any condition that can cause arrhythmia coming from the heart, which is a very broad definition and may include ischemic, hypertensive, valvular diseases, and so on. And this is the definition which was more or less included in the Heart Rhythm Society document in 2019. But this is probably an arrhythmic condition, not necessarily an arrhythmogenic cardiomyopathy. With arrhythmogenic cardiomyopathy, what we understand on this side of the Atlantic is the heart muscle condition that has an inherent risk of arrhythmia, that produces arrhythmia at the early stages of the disease, not because it has reached the end stage of heart dysfunction and heart failure, but because the arrhythmia is part of the disease mechanism and progression. And there have been some classifications of the type of arrhythmogenic cardiomyopathy, depending on which ventricle has the most obvious changes, structural and functional. So we have started calling the right ventricular cardiomyopathy as dominant right, with biventricular disease when it affects both ventricles, and dominant left when it is mainly affecting the left ventricle, still causing significant arrhythmia. A very tidy and, in my opinion, valid approach to all this has been the publication of the Padua criteria, which, if one reads carefully, will understand very well how this condition is manifests itself, and would have a very good diagnostic approach, but also an approach that would help with the management. One of the things that the Padua criteria have introduced is that we need to use the new tools in order to characterize and classify what was observed many years ago. And the new tools are the cardiac MRI with the tissue characterization, the presence of arrhythmia coming from both sides of the heart, not just from the right ventricle, and in actual fact, the more multifactorial it is, the more likely to be associated with an arrhythmogenic cardiomyopathy, and also the genetic information, which has been discussed a little bit earlier about the hypertrophic cardiomyopathy, but is also very relevant to arrhythmogenic cardiomyopathy. Of course, there are pitfalls. Of course, there is work that needs to be done in all these areas, in the interpretation of the cardiac MRI and the standardization of certain measurements. The arrhythmia is, as I said, is there and may have morphology from either of the two ventricles, but also the genetic interpretation is a task which is sometimes quite challenging, especially with a number of variants of unknown significance that we get from the genetic testing. And this may actually pose a challenge to any association between certain genetic results and phenotypic expression and risk stratification. However, there are a number of cases nowadays, especially with multidisciplinary involvement from both genetic labs and clinicians and cardiologists, where the genetic interpretation is quite safe and can help with the diagnosis of the arrhythmogenic condition and the management. So in a diagram, in a figure where things are summarized, we can still differentiate almost three types of arrhythmogenic cardiomyopathy, but essentially they have very similar mechanisms, and the change is the location of the most important changes. And I think we would have been narrow-minded to keep the definition only limited to the right ventricle. I will not go through this algorithm, just to show that we can follow a number of different pathways to get to a more precise diagnosis. And I will conclude by summarizing that arrhythmogenic cardiomyopathy nowadays has a very variable phenotype understood and observed. It has always been like this, but even more nowadays, even more so nowadays. We still need a consensus about the definitions. It is a biventricular disease. It can be affected by lifestyle changes in a positive or negative way. and prevention is indicated in patients when the risk is elevated. And if I receive any questions about the most recent guidelines, I would probably defer the question to tomorrow's session, because I think there is a session about the guidelines, or I will give you a diplomatic answer. Thank you very much.
Thank you, Dr. Pantazis, for this excellent talk. It is important to understand, as you mentioned, that this disease is biventricular disease in many cases, not only to the right ventricle. And I would like to ask you, Antonis, what do we have to expect for the future, for the treatment of this disease, apart, let's say, the ablation, apart the device, ICDs? What do you have to expect? Any help from the genetic approach?
Yeah, I mean, as Bill said, I think we are in the era now of genetic precise genetic information, better links between genotypes and phenotypes, and eventually gene editing and gene therapy, especially in those cases where haploinsufficiency, the genetic therapy can be closer than what we previously thought. I'm not saying it will happen tomorrow, but we have room to play there and possibly correct the disease with genetic intervention. So yeah, I think we can look in that direction. I think discussing actually already.
Any hot question from you, Petros, or from Professor Efthymiadis, or anyone in the room?
I don't think so, Kostas. I think in view of the time, we need to proceed. Yes.
Thank you, Antonis. Thank you for this great talk. Thank you.
And thank you, Antonis. And now we will